Hypertension, also called high blood pressure, is a condition in which the systolic blood pressure of a client is consistently above 140 millimeters of mercury, and or the diastolic blood pressure is consistently above 90 millimeters of mercury. It usually presents with no symptoms, and people could live for years with it without it being detected. Hypertension is the commonest cause of heart disease, stroke, and untimely death. Kidney damage could also result from long-standing hypertension. The World Hypertension Day is celebrated every May 17th to stress the importance of monitoring our blood pressure and effectively managing elevated blood pressure, especially amongst the 1 billion people living with it worldwide. The theme for this year is measure your blood pressure accurately, control it, live longer. Fortunately, hypertension can be managed and the complications prevented by checking your blood pressure regularly and through treatment. Worldwide, hypertension causes an estimated 7.5 million deaths yearly. In this episode of Gynae Facts, we'll take a look at a subset of people living with hypertension, the pregnant woman. Hypertension complicates 10 to 15% of all pregnancies and is the most common medical problem encountered during pregnancy. It's called hypertensive disorders of pregnancy and is a group of diseases that is one of the prominent causes of maternal morbidity and death, especially in remote parts of Africa, where women have no access to organized antenatal care. Approximately 30,000 women die yearly from hypertension in pregnancy. A diagnosis of hypertension in pregnancy is made when a blood pressure at rest, taken 4 hours apart, is equal to or greater than 140/90 millimeters of mercury. Hypertension in pregnancy is common in women with a previous history of hypertension in pregnancy, women with maternal obesity, age less than 18 years or greater than 35 years, a family history of hypertension, multiple gestations where there's more than one pregnancy or one baby, women with diabetes or kidney disease, women with hypertension outside of pregnancy. Hypertensive disease in pregnancy is further subclassified. Let's take a look at them. Number 1, pregnancy-induced hypertension or gestational hypertension. This is blood pressure elevation, which is first noticed in pregnancy after 20 weeks of pregnancy. It could occur in pregnancy, labor, or within 10 days after delivery. There's usually no protein in the urine of these women. Number 2, preeclampsia. In this case, there's a blood pressure elevation associated with protein in the mother's urine. It's a sign of increasing damage to the maternal kidney. Preeclampsia could affect the liver, the brain, and several organs in the body. Fortunately, most of the damage is reversible. Number 3, chronic hypertension. In chronic hypertension, there's hypertension occurring before the pregnancy. For a woman who does not know her blood pressure before pregnancy, a diagnosis could be made if her blood pressure is elevated before the 20th week of pregnancy. Chronic hypertension is a primary disorder in 90 to 95% of cases of hypertension in pregnancy and may either be essential in 90% of cases or secondary to identifiable underlying disorders such as kidney disease, hyperthyroidism, hypothyroidism, growth hormone excess, or use of oral contraceptives in the past. About 20 to 25% of women with chronic hypertension will develop preeclampsia during pregnancy. Number 4, chronic hypertension with superimposed preeclampsia. In this set of patients, they have pre-existing hypertension and they develop protein in the urine while pregnant. This worsens their pre-existing BP status. Number 5, eclampsia. And we pray women never get here. This is the onset of convulsions in a woman with preeclampsia. It's associated with elevated blood pressure and the passage of a massive amount of protein in the urine. A convulsion may be preceded by headaches, vomiting and abdominal pain. Untreated, mortality rates are very high. Poorly controlled hypertension in women while pregnant puts the pregnant woman and the unborn baby at risk of several challenges. It's associated with an increased risk of maternal complications such as eclampsia, blood clotting disorders such as thromboembolisms, which could lead to pulmonary embolism, abruption placenta, which is a premature separation of the placenta before delivery, damage to several organs, and an increase in cesarean delivery. Fetal outcomes include low birth weight babies, an increase in the risk of preterm delivery, and stillbirth. Management of hypertensive disorders in pregnancy begins before pregnancy. Women are encouraged to register in a hospital for antenatal care. Blood pressure control should be optimal before pregnancy and controlled during pregnancy with the appropriate medications. Commonly used antihypertensives include nifedipine, alpha-methyldopa, labetalol, and hydralazine. Weight control before and during pregnancy is also important. The use of low-dose aspirin has been known to reduce the risk of hypertensive disorders by up to 12%. Women with hypertensive disorders need more monitoring of blood pressures and blood work, and the baby is monitored via an ultrasound scan. Women with worsening hypertension may need admission for close observation in the hospital and bed rest. Delivery of the baby is conducted either through a vaginal delivery or a C-section, depending on which of these is considered safest for the mother and the baby. However, if there are challenges, the baby may need to be delivered earlier. Post-delivery management of the woman is as important as that in pregnancy. Hypertension is a silent killer of pregnant women. Don't wait for it to present with symptoms. Ensure your blood pressure is checked regularly. Let's ensure we also measure our blood pressures accurately. Let's control it and ensure we live longer. God bless you.